Welcome to the EAU podcast.
So welcome to a series of updates from ASCO GU26. We are in the kidney cancer UROONCO platform, and we are here today with Jose Karam. He's a professor at the Department of Urology Division of Surgery at MD Anderson Cancer Center in Houston, Texas. Welcome and happy to have you here today.
Good morning, Carmen. Thank you very much for having me here. It's my pleasure to be here with you today.
So today we had a very interesting discussion. There was a trial that was presented early on adjuvant kidney cancer high-risk patients after radical nephrectomy, having high-risk features and having adjuvant treatments. Can you tell us a little bit of what was presented and what can we take home out of this?
Yes, of course. So this trial, its name officially was the LITESPARK-022 trial, and it's an adjuvant trial comparing pembrolizumab plus belzutifan versus pembrolizumab with placebo. This is a phase 3 large international trial, and the hypothesis behind this trial was that pembrolizumab has been proven to improve survival in the adjuvant setting. And the hypothesis here was if we add another drug to it, which specifically here was belzutifan, that we should see even better outcomes. As you know, belzutifan is a HIF2 alpha inhibitor, and pembrolizumab is a PD-1 inhibitor, and the hypothesis was combining both will be better than pembrolizumab alone. As I mentioned, it's a large phase 3 trial, and what's interesting in this trial is that the comparison arm was not placebo. So the comparison arm was an active agent, pembrolizumab, which in the US has been FDA approved.
Would be standard of care, not to say?
It is essentially the standard of care for patients with clear cell, of course. So the entry criteria for the trial were very similar to the Keynote 564 with very few differences. Of course, patients had to be clear cell. They had to be either intermediate high risk for recurrence, which are T2 grade 4 or sarcomatoid or any T3. The other group was the high risk of recurrence, which are T4s or N1. And the third group is the patients with metastatic disease who were rendered disease-free with either surgery or other means. And the patients were stratified with two different stratification factors, one being the tumor grade, low versus high, and the other one being intermediate high versus M1 and LB. The patients included almost or a little bit over 1,800 patients total, so more than 900 patients per each arm. And the treatment was done for a total of 1 year.
Either the IV and the oral, right?
And the oral,
Yeah.
exactly. So the oral drug is once a day. The IV pembrolizumab was every 6 weeks, which is different from the Keynote 564 because at that time it was every 3 weeks.
Oh, okay.
So the dosage here is
Little more spark.
it's easier to give, I think. And the primary endpoint again was disease-free survival by the investigator. The secondary main endpoint was overall survival.
Like we had in the prior trials.
Very similar exactly to the Keynote 564. And the other endpoints that were looked at is safety, of course. The follow-up for this particular presentation was 28 months. So just a little over 2 years. So it's still relatively short follow-up for an adjuvant trial. And the data cutoff was in August of last year. The trial was supposed to enroll 1,800, but actually 1,841 patients ended up being enrolled. And with this specific trial, the actual events that happened with the disease-free survival events were 432. So this is 87% of the events that we were looking at. For the overall survival, we only got 29% of the information.
We are not there yet.
So we're definitely not there yet. So this is very immature as far as the overall survival. Ultimately, the study showed improved survival. I mean, this is the bottom line. Going through the baseline characteristics, it's what you expect. However, I think the age group was a bit younger than I expected. The median age of the patients is about 60 years, which was surprising to me. I was expecting something more in the higher 60s or early 70s.
So do you think we have a skewed population that got into this trial?
Either skewed or we're seeing more and more younger patients with kidney cancer that have aggressive disease as well.
Yes.
So it could be a combination of both as well. Up to about 2/3 of the patients included in the trial were white. More than 85% of the patients had a ECOG performance status of 0. And the disease-free survival was significant, as mentioned. Start seeing separation of the curves at about 3 months. And the separation stayed very consistent throughout. Now, the hazard ratio was 0.72. And what's interesting to see is, the therapy was given for a total of 1 year. And the separation of the curves still remained exactly the same even after that 1 year period.
Even at 2 years, no.
Even at 2 years. And, we can't say very much about 3 years at this point because we don't have that many patients followed to that end. But it's interesting to see that the effect remained consistent even after stopping the medication, which is always good to see in these therapies. We don't want to see the curves starting to come back as soon as you stop the therapy. So this was statistically significant, and therefore the study met its endpoint. When you look at the different subgroups, and these were pre-specified subgroups, you could still see a signal that the patients who received the pembrolizumab plus belzutifan did better. This is very well seen in the intermediate to high risk group. We don't really see it as clearly in the high and in the M1 NAD. And it could be because of the short follow-up, or it could be because of the small number of patients in the high group and in the M1 NAD. But I'm sure we'll see more defined results with further follow-up. And we see the effect in both the low tumor grade as well as the high tumor grade. The overall survival, as I mentioned, although the hazard ratio was 0.78, it was definitely not statistically significant.
It's very premature.
It's very premature. The curves really are not separating. You see some signal, but it's not something that is definitive in any way at this point. The safety is as expected, within the class of the PD-1 inhibitors and the HIF-2 alpha inhibitors. Almost all patients had some adverse events, which is not surprising. When you look at the treatment-related adverse events that are grade 3 or higher, the rates are significantly different. So when you look at pembrolizumab alone, it's around 18%. When you look at the combination, it's 42%. So this is quite significant and important to keep in mind.
But so we do see side effects associated with belzutifan, no new signals in terms of the immune-related adverse events, no? That's what we are...
Correct. There's no surprising adverse events. There's no overall increase in the number of side effects based on what we know from previous trials, like the Keynote 564 or others. When you look specifically at anemia, which is a very well-known side effect of belzutifan, we see that happening in 84% of patients on the combination arm. This is for any grade adverse event. See that significantly as well in grade 3 or higher in this patient population. So this is one of the most significant side effects of this patient population. The other one that's important is fatigue, as well as increase in the liver function test.
But it would not report a lot of grade 3, no? It would be only anemia.
Anemia mostly is the grade 3, exactly right.
Like 10% or how much
it's a little over 10%. So it's about 12% to be accurate. So it is, and again, it's something that is manageable. Some patients had to have interruption of their therapy. Some patients had dose reduction. So it's really important to have a physician that's experienced with managing these drugs in order for the patients to be able to handle side effects as much as possible and treat the accurately. Now, some patients had to receive blood transfusions, actually. So about 4% of patients had a blood transfusion. Hypoxia is the other side effect that we know of. Again, not surprising. But, just to summarize the entire trial, the combination of pembrolizumab plus belzutifan versus pembrolizumab alone did show an improvement in disease-free survival that was statistically significant. That was the primary endpoint. So for all intents and purposes, the trial did meet its primary endpoint. Of course, we have to do much longer follow-up to look at overall survival, which is also very important.
Especially in this population, no?
Absolutely.
But there are other issues that were present in the discussion, no?
Yeah.
But the quality of life.
Quality of life is very important.
Frequent therapies.
To these patients, because these patients, many of them are potentially cured already with surgery. So I think we have to do a better job on selecting which patients need these types of therapies. And once we have that confidence to know who needs it, we can be more aggressive with the therapy and with managing the side effects. But at this point, we're still overtreating many patients that don't really need therapy at this point. So I'm sure the patient reported outcomes will be coming out in the next few months or years. And that would be very important to see how the patients feel, how they do, how is their quality of life on therapy, and how does that differ from the combination versus single agent.
So let's say on Monday you have a patient in your clinics that would have a high risk RCC. How would you counsel it nowadays?
Yeah, I think at this point we still, this is not approved combination, so we can't really use it. So the discussion is still the same as I do now. Anybody who has stage 3 clear cell kidney cancer, I have to discuss with them adjuvant therapy as an option and discuss with them the results of the trials, the side effects, and the patient-reported outcomes. And it's a very patient-dependent discussion. Some patients want to be very aggressive and want to do everything possible. Some patients are happy with just a surgery and do not want to deal with any more potential side effects and would rather get treated if they have a recurrence in the future. So it's not a one-size-fits-all. We just have to see what each patient wants and needs.
Yeah, also maybe younger patients, no, or more proactive.
Some younger patients don't want to do anything else. Some older patients want everything to be done. So I think these are discussions that we need to set a long time in clinic to talk to our patients about, and this is not a quick 5-minute discussion. And one thing I find very useful is to talk to the patients about adjuvant therapy before surgery.
So prep them.
Prep them that there might be another option for you in addition to surgery, but you have to fit certain criteria. So that way, when the patient gets the pathology results, they're not completely surprised when they hear there's another additional option for them.
Sounds good. Thank you very much, Professor Karam, and we hope to have you again on the podcast. Thanks for your insights on all these topics that are hot in kidney cancer.
Thank you very much for having me. It's my pleasure.
Thank you for listening to this episode of EAU Podcast. To keep up to date with the kidney cancer developments, visit our educational platform, UROONCO Kidney Cancer. To keep up with the latest EAU podcasts and stay informed on the urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.